So basically, when we are taking an antenatal history, all history in different departments all have a fixed format, and it's better to stick to the format so that you know in your mind, you have sort of a checklist. You know what all has to be asked, and you know in what order it has to be asked. The order may vary slightly. Nobody is going to penalize you for taking dietary history before personal history, but some things, especially in the beginning, have to come in order. It makes more sense that way, for the simple reason it makes more sense to whoever you're presenting the case to. So the format we have is, we of course start with identification details, then we go to and I'll be explaining all these in a little bit more detail. Then we go to the parity index, the last menstrual period, the estimated date of delivery, and the period of gestation. Then we discuss the chief complaints, then history of presenting complaints. This is very similar to your medicine and surgical histories. Then this is different from, of course, your medical and surgical in medicine and surgery. This is history of present pregnancy. That is, we describe the events of the present pregnancy in more detail. Then we discuss the past obstetric history, if she has a past obstetric history. Then, of course, the menstrual history, then the past medical or surgical history, the dietary history, personal history, and also family history, which I forgot to include here. Okay, so this is the basic format. So as I said, it's always important to have a checklist. There's a very nice book by a very famous doctor, Dr. Atul Gawande. He writes a lot of books. One of his famous book is the Checklist Manifesto. So in that, it details how important it is to have checklists for everything you do in day-to-day life, more so in medical practice, because by having checklists, we don't forget. And by doing these repeatedly, we know, we have it in our mind, in the back of our mind, that these things we have to ask. So let's start with identification details. Of course, okay, so this is very simple, but why is it important? You should know. So number one is the name. The name of the patient is very important. Now, if I go and address the patient for say by bed number 2 or bed number 13, that doesn't seem nice. The patient always likes to be appreciated if you call her or him, in our case her, by names. The name of the patient is very important. When you address the patient repeatedly by her name, she feels nice. She feels that you've developed a bond with her, a rapport with her, so the patient will open up to you rather than just addressing her by a prefix like Miss or Mrs. It's always better to call her by name. Second is the age. Now, the age of the patient, and also in between, if anybody has any doubts, you can always stop me and ask, okay, or you can enter in the chat box. Second is age. So age of the patient is also very important, especially in obstetrics. Why? Because extremes of age. Okay, so less than 18, that is teenagers, and more than 35, this is elderly. If they're primary gravida, we call them as teenage primary or elderly primary. Both are high-risk pregnancies. A teenage primary is at risk of several complications, for example, hypertension in pregnancy, or late anemia, malnutrition, then CPD. So these are more common in the younger age group. In the older group, also chronic diseases are more common. So hypertension, diabetes, she may have a pre-existing condition. So these are more common. There's a higher risk of genetic diseases. There's a higher risk of congenital anomalies. There's a higher risk of abortions. So simply one simple if you statement about the age gives a lot of idea whether she is high risk or low risk, because the age itself is a risk factor. So this is very, very important. You can't ignore age. Okay, next is the education. Again, very important. Depending on the education status of the patient, we would have some idea about how aware she is regarding her pregnancy and her checkups, and how what her socioeconomic status is, and how well she would be able to understand your counseling, or how she would respond to the advice you give. So education is very, very important. Also, it helps you better communicate in which language you choose to communicate with her. So education does play an important role in any history taking. Then comes occupation. Occupation again is important. It helps us decide the plan or how her obstetric, again, certain occupations are high risk. She may be a laborer working with very having to lift heavy loads, or they are at increased risk of preterm labor, of anemia, of malnourishment, or she may be a woman who works in the IT sector whose job involves sitting the whole day or long time at the facing the computer screen for a long time, she's at an increased risk of complications related to immobility, like deep vein thrombosis. So there is a lot of it definitely does matter what the occupation is. It's very important to ask the patient the occupation, because certain occupations are at higher risk. Next comes the socioeconomic status, right? And we all know this socioeconomic strata, which strata she belongs to. I won't go into the details of this part because you all know the classifications based on PSM. And this again helps us determine how at risk she is, or what risk factors. If she's a low socioeconomic status, she's at risk of anemia, or of she has a low BMI, of different deficiencies, malnutrition. And if she's from a very well off strata, then again she's at risk of certain complications like obesity, like diabetes, GDM. So there is again a difference because of the socioeconomic strata. Then address is very important. You should know where she stays. Okay, this is sort of to complete the list. Okay, and if you need to contact her, if you want to get back to her, or if you find an abnormal investigation, you want to know where she is. Also, women living in high altitude areas, in endemic for certain diseases, it's important to know the address. So identification details basically helps build rapport, number one, with the patient. Okay, it helps identify certain risk factors as I've described, and it helps in understanding the family and accordingly giving advice. So that's why identification is very, very important. Okay, so you may take an excellent history, but your viva may only be asked on relevance of age, or different occupations and their risk factors. So it's very important to understand that identification is not to be ignored. It's very important. Okay, so altitude and OBG. So so high altitude, there's an increased risk of hypoxia. There's an increased risk of decreased saturation. Okay, so the baby can be IUGR. There could be fetal growth restriction, which has been associated with high altitude. Okay, uh, coming to the next slide. Just give me a moment. Okay. Now coming to this is a very important part of OBG, of the history taking. Okay, 1 second. Yeah. So the parity index. Now, what is parity index? Parity index basically means when we start the history, we say primi gravida, or we say gravida 2, or we say gravida 3. What does this mean basically? So this is, as I said, very, very important. Okay, so we'll start with what is gravida. So G denotes gravida. We use these capital letters to denote what these are. So G is gravida, and gravida basically means, you may be asked the definition of gravida. Gravida basically means the number of times the woman has become pregnant, including the present pregnancy. So G always means including the present pregnancy. Okay, so she says she comes to you and she says, I'm pregnant for the first time. So she's gravida 1. Okay, say she comes to you and says, I am pregnant, but my previous pregnancy ended up in a miscarriage. So she's gravida 2. Okay, so suppose she says, I'm pregnant and I have one baby and then I had an abortion. So she's gravida 3. So the number of times she has been pregnant, say she comes to you and she says, I had an earlier molar pregnancy. This is my second pregnancy. So she's gravida 2. So molar pregnancy, ectopic pregnancy, miscarriages, irrespective of the outcome and including the present pregnancy, is G. The number will denote what I'm saying. That is the number of pregnancies, including the present pregnancy, and irrespective of the past outcome, is gravida. Okay. Next comes para. So what is para? Para, very important to understand. It is the number of pregnancies in the past, that is excluding the present pregnancy, that have crossed the period of viability. And for all practical purposes, in our country and in developing countries, we take this as 28 weeks. In developed countries, they take it as 24 weeks. Okay, there is a gray area between 24 to 28 weeks, but let's not get confused. Let's not go there. For all practical purposes, when we define para in India, it is more than 28 weeks. So a past pregnancy which has crossed 28 weeks will now be called as para. So say she comes to you and she says, doctor, this is my second pregnancy. So she's gravida 2. My first baby is 2 years old. So she's para, and he or she was born at 9 months. So she's gravida 2, para 1. Okay. So say she comes to you and she says, doctor, this is my second pregnancy and I have twins. My first pregnancy is a very commonly asked question. My first pregnancy, I had twins and both my babies are doing well. They are 3 years old. So she's still gravida to para 1. Remember that. So para means the number of pregnancies, not the number of fetuses she had in that pregnancy. I hope I'm clear. So gravida is the number of pregnancies, including the present pregnancy, irrespective of the outcomes. Para means those pregnancies in the past, that is excluding the present pregnancy, that have crossed 28 weeks or that have crossed the period of viability. Next comes L. What is L? L means the number of living children. So she says, doctor, this is my second pregnancy, G2. I have one baby who was born at term and he is 2 years old. So G2, P1, L1 will be your parity index. She says, doctor, this is my second pregnancy and I have twins who are now 3 years old. So she's G2P1 L2. That's how you write a twin pregnancy if both the twins are alive. Okay, so basically this is what is L. L means the number of living issues or living children. This is very easy to understand. Then we have A. A is the number of pregnancies in the past that have ended up as a miscarriage or an abortion. And how do we define abortion? Is less than 20 weeks according to WHO. So now you'll ask me, what do we do with the pregnancies that happen between 20 to 28 weeks or 20 to 24 weeks? So this is again a gray area. You can either put them, she says I had an IUD at 6.5 months of amenorrhea or 6 months of amenorrhea. You can choose to put it in para or as abortion. Okay, that is up to you. Nobody is going to penalize you for putting it either way, because this is definitely a gray area. And by definition, WHO says an abortion is less than 20 weeks or if the fetus is less than 500 grams. So you can ask her, what was the weight of the baby at 6.5 months? And she says the weight was around 1 kg. Then you can put it as a para. Okay, so you can use the either gestational age limit, or if she remembers the weight of the baby, the weight. Okay, and you can define abortion accordingly. Okay, so you can also use E for ectopic and M for molar. So she says I had a previous ectopic, she becomes G2E1. Okay, or a previous molar, she becomes G2M1. Okay, so these, but the main ones are G, P, G for gravida, P for para, L for living, and A for abortion. So I hope this is clear. Parity index forms your basis of history. Okay, it forms the basis. Should present abortion be counted in A? No, if suppose she comes to you, she says, this is my first pregnancy, or say my second pregnancy, okay, and you diagnose her to have a missed abortion, okay, and suppose she had an abortion in the past, she will be G2A1. So A is the past abortions, not the present one. Present is her current pregnancy. We don't know the outcome. G includes all pregnancies, including the present pregnancy. All the rest are about past. All right, I hope that's clear. Okay, so this is very important to understand. Our basis of obstetric history in taking is in the parity index. If you go wrong here, you will mess up the case. So make sure your parity index is proper, it is correct. Okay, and that's very important. Okay, so we've discussed how to write the parity index. Also very important point, emphasize any important obstetric history itself, here itself, instead of keeping the examiner, that is us, in suspense. For example, suppose she is gravida 2. She says, doctor, this is my second pregnancy. My last pregnancy, I had an intrauterine demise. My baby died in utero at 8 months of pregnancy. Okay, so what will you do? You will say she's G2P1 and you will say L0. She doesn't have a living issue. And you will tell with the previous history of an intrauterine death. Tell it here only. Don't wait for your past obstetric history, because this previous history of IUD will influence your history of present pregnancy. You will have to ask negative history. So now if you miss this history now and then you tell this in the past obstetric history, then the examiner will try to go back to your present history of present pregnancy and see if you had asked all the relevant information or relevant negative history. Am I clear? So if there's any important obstetric history, for example, especially which may have an effect on the present pregnancy, a previous intrauterine death, a previous stillbirth, a previous cesarean section. She's G2, P1, L1 with a previous cesarean section. Mention it in the beginning only. So any important past obstetric history, mention it there and then. Okay, this gives a lot of importance. This examiner will take in a very good way that you have told an important point in the beginning, which may affect your present pregnancy history. Am I clear? Okay. Now, next step, very important again, again, if you go wrong here, you will mess up your case. So calculating the LMP, the EDD and the POG. The LMP is the last menstrual period. It is actually the first day of the last menstrual period. Okay. So why is this important? We use this to calculate the period of gestation because we don't know when ovulation or when fertilization happened. We don't have that date. The only date we can correlate with and go backwards is by the first day of her last menstrual period. So it's important to ask the first day. Many patients remember their period by the last day. So always clarify, was this your first day or your last day, and try to get the first day. Secondly, we need to calculate the estimated date of delivery. And how do we calculate this? By Naegeli's formula. Okay, and what is Naegeli's formula? Okay, so just a doubt. Okay, so Prashant is asking, what is IUD, what is stillbirth, what is abortion? Just a second, Prashant. So what is an IUD? Okay, first, what is an abortion? Abortion we've already discussed, it is basically a loss, fetal loss less than 20 weeks or less than 500 grams. Okay, so any baby who is lost, or maybe the fetal heart disappears, or she goes into very early labor at 18 weeks and expels the fetus. So irrespective of what happens, if the loss happens before 20 weeks or if the weight of the fetus is less than 500 grams, it is an abortion. Then what is an intrauterine death? An intrauterine death is when death of the fetus occurs in utero, and we usually define this after the period of viability, which is 24 or 28 weeks, depending on where you are. Okay, so say a patient comes to you at 29 weeks and you examine her and you find the fetal heart is absent. You confirm with an ultrasound. This is an intrauterine death. What is a stillbirth then? A stillbirth is basically a baby who is born without any signs of life. This could actually be an intrauterine death, or it could be an intrapartum death. That is, the baby may have been alive, but during labor, some event happened. There was fetal distress, or there was an acute abruption, that when the baby was born, the baby was born without a heart rate. Okay, so stillbirth includes all intrauterine deaths and all intrapartum deaths also. That is, during delivery, the deaths which happen. Okay, so basically stillbirth basically means a baby born without any signs of life. Okay, so going back to EDD. So EDD is calculated by Naegeli's rule. Okay, Naegeli's rule basically means to the first day of the last menstrual period, we add 9 months plus 7 days, or we subtract 3 months and then add 7 days. This is what is Naegeli's rule. Okay. So it's very important to calculate the estimated date of delivery, and also remember that the EDD falls at 40 weeks. Okay, just excuse me for a second. Okay, so EDD falls at 40 weeks. And so remember, when somebody asks you, when does the EDD, it is not 37 weeks. Remember, 37 weeks onwards means a term pregnancy. But EDD falls at 40 weeks, and around 6% of women will deliver exactly on their estimated date of delivery. Now, what is period of gestation? POG is calculating how many weeks she is on the day you are taking the history. And this you calculate from the LMP. Okay. So say a patient comes today, and the patient today is 16th August, right? And the patient says my LMP was on 4th of May. So how do we calculate the period of gestation? So now we go backwards. How many days left in May is 27 days plus June plus July plus today. This is 7 plus 8, 7 plus 1 plus 6 is 14. And this is 10. So this would be 14 weeks and 6 days. So when she comes to me, she is 14 weeks and 6 days. This is how we calculate the period of gestation. So it is the weeks of gestation on the day you examine her, and it is calculated by from her LMP. How does this help us? Why is this important? Because we know which trimester she is, and we know in which trimester what complications happen. So if she's 14 weeks, we know what to ask. We won't ask quickening. We won't ask, we will probably not ask iron calcium would just have been started. We won't ask whether she has had her anomaly scan. Okay, we won't ask whether she's had leaking. So we will ask questions relevant to 14 weeks, 6 days. We'll ask her if she's had her NT scan. We'll ask her if she's taken folic acid. Okay, these are the questions we will ask her. So you have to know the POG to understand what at what period of gestation, what happens, and accordingly ask the relevant question. Okay. Now coming to the next part, that is the chief complaint. It is also known as the presenting complaint or the reason for encounter or the reason for presenting the patient. And how do we start? We always start by the pregnancy duration. So patient, so we say gravida 2, para 1, living 1 at 8 months of amenorrhea. So always start with the pregnancy duration, and this is always in the patient's terminology. We know how many weeks she is, okay, but we will tell it in the patient's terminology, because patient will tell us I am 8 months pregnant, or I'm unless she's a super intelligent patient or she knows her obstetric history very well, and she will, and many patients do now tell us that I'm these many weeks. If she tells you the weeks, tell the weeks. If she tells you the months, you'll tell she is 6 months amenorrhea or 5 months amenorrhea or 4 months amenorrhea. Okay, and then mention the chief complaint with abdominal pain or with bleeding PV or with decreased fetal movements or with reduced fetal growth as told to her by the doctor. So these are the different complaints that she may have, or increased urinary frequency or burning micturition or fever or whatever the complaint is, in chronological order, as you do with any other medicine case. Okay, I will repeat. Chief complaint has to start with the months of amenorrhea or weeks of gestation if the patient tells you, however she tells you. Mention the chief complaint in chronological order. Then what do you do? Then comes the history of presenting complaint. That means, so many of you fumble here. After the chief complaint, you go straight to first trimester history, then second trimester history. And by the time you finish the third trimester history, you've forgotten, or the examiner has forgotten about what was the chief complaint. So always elaborate before going to HOPP, that is history of presenting pregnancy. First complete your chief complaint history, that is HOPI, or what you say in medicine has history of presenting illness or history of presenting complaint. So describe the complaint in detail, also elaborate negative history. For example, patient comes to you, she's a primigravida, she comes at 7 months of amenorrhea with abdominal pain. Okay, this is your chief complaint. Okay, now what will I say? I will elaborate the complaint in detail. I will say the pain started 1 day back. It was regular in onset. The frequency was gradually increasing. The intensity was increasing. It was radiating to the back. And then elaborate the negative history. What will you say? You'll say there was no history of leaking. There was no history of bleeding. There was no burning micturition. There was no history of decreased fetal movement. So basically, by the negative history, you're basically telling the examiner, you know the causes of abdominal pain at 7 months of amenorrhea. What could they be? It could be preterm labor. That's why I asked the intensity and duration and all that. It could be antepartum hemorrhage or abruption, which can cause abdominal pain. So that's why we asked bleeding. It could be PPROM, which could eventually led her to go into labor. That's why we asked history of leaking. It could be UTI. That's why we asked history of burning micturition. So you should basically, by telling the negative history, you are telling the examiner that yes, I know the causes of pain abdomen, or yes, I know the causes of bleeding, or yes, I know the causes of whatever complaint she has, which are very few in obstetrics compared to medicine and surgery. So negative history is very important. It should come with the history of the presenting complaint. Next comes the history of present pregnancy, and this is your trimester wise history. This is also very, very important. Okay, so I've tried to elaborate what all is important, what all should be asked. Okay, and usually with the first thing we say is she was spontaneous conception. What does that mean? That means that she did not require any fertility treatment. So you have to ask the patient, especially if she has a long married life or if she has a long inter-pregnancy interval, or if she has been trying for quite some time and has not conceived and then she conceives, you have to ask her, did she conceive with any fertility treatment? Why is this important? Okay, so as I said, everything you ask has an importance. If you understand that, or if you question yourself, why did I ask this, you will understand the topic better, you'll understand history taking better. Okay, why? Because women who have conceived with ovulation induction or who have had in vitro fertilization, they are at risk of several complications. For example, if she had required OI, she may be a case of anovulation. That means she may actually have had PCOS. And by asking this history, you get to know her history of PCOS. And PCOS women are in increased risk of having abortions and GDM in pregnancy. Okay. If she was an IVF pregnancy, there's increased risk of multiple pregnancy, increased risk of ectopic pregnancy, increased risk of anomalous babies. So you know the that's why it's important to ask. Okay, so don't just simply say do when you take history now you understand better, you now you know why you're asking this. Okay, next, when was her first antenatal visit? So if she comes to you at say 7 months, you need to ask her when was. Many women come to us in the third month onwards. Very few actually, in unless they're educated or they're aware, they very few come to us in the first trimester. So they miss the first trimester completely. So you need to ask whether she actually was booked in the first trimester and when was her booking visit. How is that important? It's the first trimester is important because she would have a dating scan, and that's very important to corroborate your dates with the or recalculate the dates with the LMP. Okay, it's very important because you'll know whether she took folic acid or not. Okay, whether she had any other she was told to have any complication, all her antenatal investigations would have been done. So when was her first antenatal visit? If it was in the first trimester. Okay. Were antenatal tests done? Again, very important. What are the, now here the question that can be asked. So in your history, you would say all her investigations were done. The examiner will then stop you and ask you what investigations were done. So what are the routine investigations we done? We get a blood group plus RH typing. We get a hemoglobin. Okay. We get a viral marker screening done, that is HIV, hepatitis B, and hepatitis C. This is done in some areas endemic. Usually it is HIV and hepatitis B. We screen her for syphilis, that is by getting a VDRL test done. In many endemic areas, in India, it's as such as endemic. So the recommendation is to get a TSH to screen for hypothyroidism in all women in the first booking visit. So we get a TSH. We screen for overt diabetes or pre-gestational diabetes by doing an RBS or a HbA1c. Again, India is known to be a high risk area for diabetes. This is pre-gestational. This is not GDM. GDM we test for in the 24 to 28 weeks. In the first trimester, we check for pre-gestation. That means she may have been diabetic, but she doesn't know. So we use this as an opportunity to test her. Then we also get a urine routine and a urine culture to rule out asymptomatic bacteriuria. So these are the routine tests, and this is a very commonly asked question. What are the routine antenatal tests that you get? We don't do TORCH. Remember, TORCH is not done routinely. Datta writes some tests, your book, standard books, but these are not done. So please don't get confused. OGTT, Prashant, is not done in the first trimester. It is done between 24 to 28 weeks. If you go to my Instagram, I have done a small video and YouTube also on screening of GDM in pregnancy. It's a very short 2-minute video. You can go through it. So in the first trimester, we screen by doing an RBS, HbA1c, or in fact, even an FBS. And this is for pre-gestational diabetes. That means she may already have diabetes and she may have become pregnant. For GDM, we screen between 24 to 28 weeks by a OGTT. Okay, and that is more in when we come to the third trimester, I will elaborate more. Okay, how was the pregnancy diagnosed? Most women will do a urine pregnancy test at home. If they come to the hospital in the first trimester, we also do a dating scan to confirm pregnancy. Of course, the first thing that the doctor should do is a clinical examination. Okay, but nowadays, a clinical examination, instead of that, most women will get an ultrasound done in the first trimester, which is called the dating scan. A scan done between 8 to 12 weeks of pregnancy is called the dating scan, because that is the best time we can calculate or confirm whether her LMP matches the period of gestation based on the ultrasound. Okay. And next, going with this, does she have a dating scan? Okay, so this is the next thing we will ask her. Does she have a dating scan? Also in the first trimester, this is the second scan we do. So in the first trimester, we do two scans. One is a dating scan and the second is a scan done between 11 to 14 weeks. This is called an NT-NB scan. It is also, it is basically a scan done for screening of Down syndrome and is now universally recommended. Okay, so this is done, NT means nuchal translucency, NB means presence or absence of nasal bone. It has been found in babies with Down syndrome. There's an increased nuchal translucency, that is the fat at the back of the neck, and there is an absent nasal bone. So this is now done routinely in all pregnant women. Which one to follow? If dating scan findings not coinciding with the POG, then we follow the dating scan. So remember, the first trimester scan is always the best scan to date the pregnancy. Okay, so it is done between, just hold on for a second. What happened? Sorry, 1 second. Sorry, that was my son. Okay. So going back to dating scan. So if the woman is unsure of her dates, or if you feel there is some problem, the date is not matching, always go with the first trimester scan. Okay. If the disparity between her period of gestation based on her LMP and the period of gestation based on the scan is more than 5 days, some books say 7 days, then we always follow the dating scan. Okay. So if the disparity is more than 1 week, we always follow the dates given by the first trimester scan. Okay. Continuing further, what else will be asked in history? Okay, very important. And this is very recent now, so I thought I'll include it. Has she been vaccinated against COVID? And many of you may miss this because now, but you should not, because it is now something which we should routinely be asking. If she's not, please ask her to get vaccinated in any trimester with any of the available vaccines, because COVID in pregnancy has been found to, if it happens, the severity of COVID in pregnancy is much, much higher. Okay, so chances of her having severe COVID is higher. So please ask her if she's vaccinated against COVID and counsel her if she's not. Was she told to have any risk factor? So she comes to you, this is your history, you're taking a history. So in the first trimester, was she told to have a risk factor? Was she a known case of kidney disease, of liver disease, of heart disease, or was she told that her age is more, or whatever? Was she told to have a risk factor? Was folic acid started preconceptionally, which is ideally what should be done? If not, was it started in the first trimester? What does folic acid do? It prevents mainly neural tube defects. Okay. So folic acid, if started preconceptionally, will prevent neural tube defects. It will also help otherwise. It decreases the incidence of abruption. It prevents dimorphic anemia. Okay, so it is essential that the woman should have been started, if not preconceptionally, at least in the first trimester. Okay, then complications. Was there any history of bleeding in the first trimester? That is threatened abortion. Now she comes to you at, say, 8 months with hypertension or 8 months with bleeding. She comes to you with antepartum hemorrhage and she says, in the first trimester, I had recurrent episodes of bleeding. Or if she comes, or history of excessive, so this is important. Okay, a history of threatened abortion is associated with increased risk of preterm delivery, increased risk of intrauterine demise, and increased risk of abruptio placentae. Okay. History of hyperemesis gravidarum. History of urinary tract infection. So if the woman has recurrent UTI, she's at increased risk of developing UTI or pyelonephritis later on. Prashant, at least 2 months preconceptually, folic acid should be given. In fact, some books say 3 months, some recommendations say 2 months, not 1 month. Okay. Then, okay. And last but not least, in the first trimester, what is important? We have to ask history of radiation exposure, and that is significant radiation exposure, teratogenic drug exposure, and history of fever with rash. Okay, basically we're thinking of problems that which are teratogenic, that means can affect the fetus, okay, and can cause anomalies. So it's very important to ask this history. I won't go into too much detail about what radiation, what drug exposure, what fever, rash, but this is important to ask. Okay. Now coming to the second trimester. Okay, second trimester, you have to ask if she has started her iron and calcium, mainly multivitamins for those in women in developed countries, but we basically look for iron and calcium intake, because prophylactically we start all women as we start all women on prophylactic dose of um, uh, iron and calcium starting from the 14th week onwards. That is the second trimester. Prashant, you're asking something about hyperemesis. Okay, so excessive vomiting basically means she's unable to tolerate even liquids. That is when we call it excessive. There is no cutoff, okay, but there's something called the puke scoring. Go and read it up. Puke scoring, okay. Pregnancy, a unique quantification of MS's, I think is the full form. Okay, but go and read up on this. Again, I have a small video on hyperemesis. You can check that out. Okay, but this is how we score. So there's no fixed episodes per day to define, but anyone who is having excessive vomiting, who is intolerant to even taking liquids, is called as hyperemesis. Has she received routine pregnancy immunization? What is routine pregnancy immunization? It is by the government of India, 2 doses of tetanus and diphtheria. The first dose given as early as possible, but usually we give in the second trimester, and the second dose repeated after a month. So we give tetanus and diphtheria. Before 2018, we used to give tetanus toxoid. Now we give tetanus and diphtheria, 2 doses, 1 month apart at least, the first dose as soon as possible. This is the recommendation. If this is a second pregnancy within 3 years of the first, then we just give a TD booster dose. Okay, the ACOG says give Tdap. Okay, this is tetanus, diphtheria, and pertussis. The Tdap should be given in the third trimester. Okay, again, I've done a video on this. You can go and look through that. Okay. Okay, Tdap, as you said, Prashant, Tdap is recommended by the ACOG. So ACOG says give 1 TD and then the second Tdap in the third trimester. Indian guidelines are still, Ministry of Health and Family Welfare still says 2 doses of TD. Okay, but in private practice, many practitioners give the second dose as Tdap because these are the ACOG recommendations. Okay. Next is, when did she appreciate quickening? Okay, she appreciates quickening. And why is this important? What is quickening? First of all, quickening is when the woman first appreciated fetal movements. This is important because this will help you corroborate the dating of pregnancy. Okay, how? Because many women, so basically when does quickening happen? Usually we say 20 weeks for a primary and 18 weeks for a multi. Okay, so why this difference? Because a primary is appreciating it for the first time. She may not know that this is fetal movements. Okay, so 20 weeks and her abdomen is a little tauter compared to a multi. Now, so usually women very well remember the day she first felt fetal movements. It's a very special moment for her. So when she first felt fetal movements, she will actually remember the exact date. And if you take that date as 20 weeks, you can go back in time and see if her LMP was correct. Especially in women who have doubtful dating, you can use this 20 weeks and 18 weeks time of quickening and use it to confirm whether her dating was right or wrong. Okay, so this is why quickening is important. Okay. Okay, Prashant is asking why early in multi. Same reason as I said, it is early in multi because of the woman is more experienced. She knows how fetal movements feel like. Just give me a moment. Okay. So moving on. Okay. Moving on. Okay. Was a level 2 ultrasound done? Now, what is a level 2 ultrasound? A level 2 ultrasound basically means an anomaly scan, or what is called a TIFA. TIFA basically means targeted imaging for fetal anomalies. Okay, so targeted imaging for fetal anomalies. T is targeted eyes imaging. F is for fetal anomalies. And this is done usually between 18 to 20 weeks because majority of anomalies, okay, say she had the baby has, fetus has a renal anomaly or a cardiac defect or a diaphragmatic hernia. Most anomalies can be picked up this early, or a neural tube defect. Okay, some may be picked up late, especially cardiac defects can be picked up later on also. Okay, but most anomalies are picked up by this age, and usually a TIFA is done between 18 to 20 weeks. Okay, next. Was biochemical testing for Down syndrome done in the first or second trimester? And these are things which are now commonly being done and universally recommended. That's why it's important to incorporate this in your history taking. So what are the biochemical markers we do? We do a double marker. Okay. When do we do this? Between 11 to 14 weeks. This actually comes in your first trimester history. And we do a triple or a quadruple marker. Nowadays, triple is not done. We do a quadruple marker between 16 to 22 weeks. Both are markers, or both are screening tests for Down syndrome. Okay, I remember in 11 to 14 weeks, we also did the NT scan. Along with that, we do the double marker, which is basically beta HCG plus PAP-A. Okay, and quadruple marker is beta HCG, unconjugated estriol. Okay, then inhibin A and alpha fetoprotein. Okay, so these are the 4 markers that come in quadruple marker. This is done in the second trimester of pregnancy and is now universally recommended. Okay, was an OGTT done? Remember, Prashant was asking when was it done? So this is done between 24 to 28 weeks, and we either advise the woman a DIPSI or a DIPSI test, EIPASI, which is the Indian guidelines, or we advise the patient and international guidelines, which is the 75-gram OGTT. Okay, so the DIPSI says basically that you give the woman 75-gram glucose irrespective of her prandial state. That means she may be fasting, she may have just had a meal, and after 2 hours you repeat the you check the venous blood sample. If it is more than 140, that means she is GDM. And this is basically done because many women don't come for follow-up visits because IAD PSG, this is the IAD PSG guidelines, say you do a 75-gram OGTT where you first ask the woman to come fasting, then give her 75-gram glucose, then take a 1 hour and a 2 hour sample. So many women don't come fasting or don't come back to it at all. So it's better to get it done at that time only. A single step screening and diagnostic test, that is the DIPSI 75-gram glucose test. DIPSI and OGTT are, so DIPSI, so OGTT, there are many types of OGTT. Okay, DIPSI is one type. OGTT means oral glucose tolerance test. So any test where you're giving glucose or glucose low to the woman and checking her blood sugar is a tolerance test. DIPSI is one kind, and the IAD-PSG is one another kind. Okay, so this is the international guideline, this is the Indian guideline. You should know both because both are being done in our country. Has her blood pressure been checked? Because now is the time in the second trimester where preeclampsia will set in. Okay, so check her BP records, ask the patient whether her BP is being checked, whether her BP is low or high. Okay, now also ask whether she's had any pain, any leaking and bleeding. So this is irrespective of her chief complaint and her history of presenting complaints. This has to be asked in the trimester history also. Okay. History of UTI, vaginal discharge, fever. These are all basically we're looking for infections. Infections can cause preterm labor. Okay, and other complications also. Okay, also take her dietary history. This will again come in the history again. When you take a dietary history, you can include it there also, but you can also include it in the second trimester, whether she is able to take a balanced diet or not. In the third trimester, what extra you need to ask? You should now ask whether she's appreciating fetal movements well. Again, ask history of high BP. Again, ask history of taking iron and calcium supplements. Has an ultrasound been done for fetal growth? So usually after we get a dating scan, and this has come as a question in the INICT recently, dating, how many scans do you do in pregnancy? We usually get a dating scan, then the TIFA scan, then, sorry, a dating scan, then the NT scan, then the TIFA scan. These three you have to get done. And then we usually get an ultrasound for fetal growth in the third trimester. Many obstetricians get it done between 28 to 32 weeks. There are no fixed guidelines. Then again, one scan at term. Okay, some women don't get this scan and directly a scan at term. Okay, so this again depends on your clinical examination. If you're expecting IUGR, suspecting IUGR, or suspecting oligohydramnios or polyhydramnios or macrosomia, you get your scan accordingly. But roughly between 28 to 32 weeks, a scan is done, and then roughly at term. These two, there is no recommendations. Dating scan definitely has to be done. NT scan definitely has to be done. TIFA scan definitely has to be done. Again, history of bleeding, pain, and leaking, history of UTI, and again, ask her how frequently she's been coming for antenatal visits. We all know that till 28 weeks, we call the woman every month. Okay, and then till 36 weeks, we call her every 2 weeks, and then till delivery or till 40 weeks, we call her every week. This is the usual pattern in most places that is followed. However, the WHO says at least, not the WHO, the Ministry of Health and Family Welfare says at least 4 visits, including the booking visit, and WHO says at least 8 visits. Okay, if you calculate this will come out to be around 14 to 15 visits. Okay, this is ideal. Every month till 28 weeks, then every fortnightly, and then every week. WHO says 8 visits, Indian government says 4 visits. Okay, this is again an important question. It's been asked in several exams in the past. Okay, so that we're done now with our chief complaint, history of presenting complaint, and history of presenting pregnancy. Now comes the past obstetric history. This is very important. Okay, it's very, very important. If there is a significant past obstetric history, mention it in the beginning only with your parity index. Okay, otherwise, so total number of visits, ideally, yes, would be 12 to 14. Okay, if you calculate the ideal visits, it's 12 to 14. Okay, now if the woman is a previous para, that means she has a previous baby who has crossed the period of viability, what all should you ask in the past obstetric history? You should ask, how old is that child, or how long back was that delivery? Okay, that's the first thing. Did she have any antenatal risk factors? Did she have preeclampsia? Did she have GDM? Did she have placenta previa? Did she have IUGR? Why? Because all these can recur again. Okay, so did she have malpresentation? All these risk factors are known to recur again. So it's very important to ask, what risk factor did she have? What was her period of gestation at delivery? Very important. Okay, did she have a previous preterm delivery, or a previous term, or a previous post-term? Post-term can recur, preterm can recur. Okay, if preterm, what was the reason? Was it a spontaneous preterm labor? Because this can recur. Was she an induced preterm labor? Say she had severe preeclampsia and she was induced at 34 weeks. So what was the reason for her preterm delivery? Okay, mode of delivery. Was it a vaginal delivery? Was it a cesarean delivery? Was it an instrumental delivery? I didn't put that here. Okay, so was it an instrumental delivery? If it was a vaginal delivery, did she go into spontaneous labor, or was she induced? Because if she was, as I said, past dates or post-term pregnancy tends to recur. Okay. If it was a cesarean section, this is a separate topic in itself. We won't be discussing this, but if she was a previous cesarean, what was the indication? Okay, was it for a recurrent indication like CPD, or was it for a non-recurrent indication like breech presentation? Okay. Were there any intrapartum or postpartum complications? Okay, so if you ask a history of whether she delivered normally, you ask her what was the duration of labor. Okay, was there any difficulty during delivery? Did the baby cry at birth? Okay, or was the baby taken to the nursery? Did she have postpartum hemorrhage? Did she receive blood transfusions? Okay, was there a tear which had to be, or an episiotomy which had to be sutured? All this is relevant. Okay, why is it relevant? If she had PPH, we again know if she had retained placenta, it can recur. PPH can recur. Okay, maybe she was anemic, she received blood transfusions. We need to know that. Maybe she's anemic now also. Okay, cesarean, of course, is important because this is a previous cesarean section. The whole you have to now decide the mode of delivery. So it becomes a completely separate discussion altogether. Okay, so all these questions are very important. You're asking them for a reason. Everything you ask has an effect, should have an effect on the whatever you ask. Think whether it will have an effect on the present outcome. Okay. Next, contraception, if any. Okay, so if she was using any contraception, for example, if she was using OC pills, okay, or if she was using a multi-loader or copper T, okay, all this may not really have an effect on the present pregnancy, but you may ask, you may want to know because it will influence her decision of contraception again following this delivery. Okay, so contraception is important. Okay, and how is the baby doing? Was the baby alive? Is the baby does her child are the milestones all right, or is there any delay in the development? So all that is important. Again, it influences your present pregnancy. If she had a previous abortion, how long back? 2 years back, 3 years back, 6 months back? At what period of gestation did she lose the baby? Was it a mid-trimester abortion? Then you should start thinking of things like cervical insufficiency. Okay. Or maybe a uterine anomaly. Okay. Or was it a first trimester abortion? Was it a spontaneous abortion or did she have an MTP? Okay. What was the reason for the MTP? Was it because it was an unwanted pregnancy, or was it because there was an anomaly in the fetus? Was any intervention done? Was a dilatation and evacuation done? Okay. What was the cause or the reason of the abortion? If does she know whether the fetus was sent for karyotyping? Was it a genetic problem? Okay, or was she diagnosed to have antiphospholipid antibody syndrome? So you need to ask if the previous abortion was followed up by some sort of workup, if she knows the reason, of the doctor has told her the reason for that loss. Whether she had any post-abortal complications, like did she have anemia, did she have go into sepsis, okay, and similarly if she had any contraception after. So all this is important because it will affect your present pregnancy. Okay, now quickly let's complete the list. And I'm saying quickly not because it is not important. These are very important, but because we are running out of time. So the last menstrual period, again, the first day of the last menstrual period, and very important whether she had previous regular cycles or not. Why is this important? At least 3 previous regular cycles. This will again help us confirm the dating, because we know that if her previous cycles were regular, ovulation would have occurred mid-cycle, and that will tell us that yes, we can rely on her first day of LMP. Okay, then whether she was taking any previous hormonal contraceptions, because OC pills will, what will they do? They will inhibit ovulation. So again, we don't know when ovulation happened, and we may not be able to rely on her dates for dating. Whether there was history of menorrhagia previously. Why? Because this could then have led to her having anemia. Past medical surgical history. Okay, so whether she's a known case of hypertension, diabetes, any other chronic liver disease, she's a known case of a heart disease or kidney disease, anything that may affect her present outcome. Whether she has a history of a surgery, she may have a previous history of a cesarean section, or maybe she's had a laparotomy for some intestinal obstruction. So how would this matter if we end up doing a cesarean again for her, or we end up doing a cesarean for her? This may lead to this intraoperatively, we may find adhesions, and that may affect our outcome, our operative outcome. Okay, so that's important. Family history of preeclampsia and the patient's mother is very important. So if the patient's mother had preeclampsia, she is at risk of developing preeclampsia again. Okay, history of hypertension and diabetes in her parents or first degree family members, and history of genetic diseases in the family also is very important to ask. Okay, dietary history. Okay, so why is it important? Because the woman may have a low BMI or a high BMI. She may be anemic, she may be diabetic. In all these, her diet a proper dietary advice should be given. So what should you do as an undergraduate student when you're taking history? Calculate the calorie. So this is if you have time. Okay, so remember in the exam, dietary history is time permissible. Okay, is what usually I believe in, because you take so much time taking the history, just quickly ask her and then calculate the calorie intake And very important, what we're looking for if she has a deficit. Calculate the protein intake again and see if she has a deficit. Okay. See if the diet includes anything harmful. Maybe she has 5 cups of coffee a day. Okay, like I do. So then that is harmful. She should not be having more than 5 cups of coffee a day. Counsel the patient. Okay. And so when you're taking a dietary history and you realize her diet is not adequate or she's taking some harmful substances, then you have to counsel as even though you're an undergraduate, you're an intern, you still can counsel the patient and tell her to improve her diet. Personal history, bowel and bladder habits, normal urinary frequency increases normally in the first and the third trimester because of the uterus, okay, and other reasons also. She may be a smoker. She needs to cut down on smoking. She needs to cut down on alcohol consumption. There's a risk of fetal alcohol syndrome. uh, Exercise, she may be an athlete. She'll ask you whether she needs to continue exercises or not. You need to advise her accordingly. You need to know whether she's getting enough sleep or not, and any other factor which can influence pregnancy or may be of concern to the patient. Very important here is domestic violence. Very less talked about, but very important. Many patients of me come to me, many patients come to me with a history of domestic violence. Okay, so please try to include this in your history. It's very relevant in uh, today's day and age where there's so much awareness now. Okay, so to end, what should you do at the end after taking a history before moving on to examination? In your mind or write it down, summarize the history. Okay, how do you summarize the history? What are the important points? Number one, age, very important. Number two, parity, very important. She's primary, multi, what is she? She may be a grand multi. Okay, number three, the period of gestation, how many weeks she is, because accordingly you will arrive at a differential diagnosis. Number four, what is her chief complaint? Number five, any other significant history in the present pregnancy, history of present pregnancy. And number six, any significant past history, past obstetric history. Maybe she's previous cesarean, maybe she had a previous IUD, maybe she has recurrent pregnancy losses. So in your mind, you should summarize the history, because if you are summarize the history, you're able to arrive at a diagnosis. In obstetrics, you will usually arrive at a diagnosis in the history, or the patient will tell you. Very rarely you will have to build a list of differential diagnoses, but this diagnosis will help you know what to look for on examination. The patient may say, my BP is high. You know now to look for, you have to examine her blood pressure. You have to do a cardiac examination. You have to look for fetal growth restriction, preeclampsia can cause IUGR on abdominal examination. So once you arrive at a diagnosis, you know what to look for in the examination. That is why history is very important. Okay, so that ends the class, and